I'd like to welcome everybody to today's webinar entitled Genetics and New Developments in Screening and Testing for Hearing Loss. I'm Will Eiserman, and I am the Associate Director of the National Center for Hearing Assessment and Management at Utah State University, which is funded by the Maternal and Child Health Bureau to serve as the Eddy National Technical Resource Center. And as a part of that, we offer periodic webinars on topics relevant to early childhood hearing and hearing detection efforts. And today's webinar is just one of those webinars. This webinar is being recorded and will be available to stream on our website at infanthearing.org in the next couple of days. So if anything disrupts your full attention to today's webinar, know that you can access it in the next couple of days on our website. And keep that in mind too, in case there are folks that aren't attending live today whom you think might benefit from the information that is being shared today. So I'm going to turn off my screen share and give our presenter an opportunity to share his screen. Our presenter today is Dr. Elliot Shearer, who is an assistant professor of otolaryngology, head and neck surgery at Harvard Medical School. Dr. Shearer is also a practicing pediatric otolaryngologist at Boston Children's Hospital, where he cares for children with a wide range of ear, nose, and throat disorders. He has a special interest in the surgical management of pediatric ear disorders, including hearing loss. Dr. Shearer is internationally recognized for his work in developing a new genetic testing platform for the diagnosis of hearing loss, and has written many research articles and several book chapters on the subject. Dr. Shearer also studies ways to improve newborn hearing screening tests using technologies and ways to improve outcomes for children with cochlear implants. So without further delay, let me introduce Dr. Elliot Shearer.
Thanks for the introduction, Will, and thank you so much for having me. I'm really honored to be invited to be speaking to you all today. And first of all, I'd like to thank you all for being here and taking time out of your very busy schedule and your very important jobs to learn about genetics. So I'd like to just say I have no conflicts of interest. I'd like to start by just changing or reframing how many of us think about hearing loss. And what I mean by this is that if we think about another diagnosis or symptom, if you think about someone who comes into the emergency room and they have severe chest pain, you don't have to be a physician to know that they may be having a heart attack. Now, when I was a medical student or an intern, and if I was in the emergency room, and if I recommended immediately that the patient go to the cath lab for cardiac catheterization for the symptom of chest pain, which is really just a symptom, I would have been laughed out of the room, because we all know that we need to come up with the diagnosis first. So that means doing things like taking a history, physical exam, getting vital signs and labs, and then doing tests like an EKG. Because you want to make sure that you're diagnosing a heart attack before you bring the patient to the operating room. And you want to make sure it's not something like acid reflux, which you can treat just with omeprazole and also has a similar symptom. So I've realized that as an otolaryngologist and a cochlear implant surgeon, that I treat patients that have a symptom on a daily basis that we don't have a diagnosis for. So what I mean by that is that we have a symptom of hearing loss, and this is a downsloping, mild to severe hearing loss that you can see here that's symmetric. And I take patients like this to the operating room for a cochlear implant. But really, often we don't have a diagnosis. And so what I'd like to try to get us to focus on is the importance of diagnosis and how to reframe how we're thinking about hearing loss, which is really just a symptom of an underlying process that's different. And this really does affect patient care. So what I mean by that is that if we diagnose this patient with the gene MyH14, this is a stable hearing loss, and it could look like this for the rest of their life. So that reframes the conversation that I have with this individual. They may decide that they want to use hearing aids instead of cochlear implants if their hearing is going to be stable for years. On the other hand, this same symptom, the same audiogram, I could provide a diagnosis of ACTG1, which is a gene that causes quite rapidly progressive hearing loss. And again, that may reframe our discussion around hearing aids versus cochlear implants. This same individual with the same hearing loss symptom could also have congenital CMV infection. And I think everyone on this call today knows that if you're not talking to a patient who has CMV about valganciclovir when they're an infant, then you're not providing the most up-to-date care. So we know that treating children with congenital CMV with valganciclovir can slow or sometimes even reverse the hearing loss. And then it's very important now, and we'll be talking about this more later, but this individual here could have this symptom of hearing loss and have a diagnosis of OTOF or otoferlin hearing loss. And there are now 2 clinical trials that are enrolling or starting to enroll individuals for gene therapy. And so again, the diagnosis totally frames the discussion that I have with the individual and the family in clinic. As opposed to just treating a symptom, we need to treat and think about the diagnosis. So our improved diagnostic ability has really changed dramatically over the past 15 years. And it's been brought about by new high-resolution CTs and MRIs, which really show the inner ear anatomy in a way that we haven't been able to before. This is an example of a cochlear nerve hypoplasia or aplasia, shown here with the white arrow. In many institutions, we're performing CMV testing on a universal basis or for individuals who have referred on their newborn hearing screening. So this has drastically increased the number of children with CMV that we detect. There's also tools like electrocochleography. This is something that my team uses in the operating room when we're performing cochlear implants. And we're able to get a better understanding of the physiology of the inner ear using these measures in a way that wasn't possible even 10 years ago. And then the focus today that I'm going to talk about is genetic testing. And I'll show you how this has changed dramatically over the past 15 years. And it really has altered how we care for individuals who have hearing loss or who are deaf or hard of hearing. So what this means overall is that in my clinic, where I see majority of children who have hearing loss, we're able to come up with a diagnosis in most cases. So this is one study from Korea that shows this very nicely. So they had 119 children with severe to profound sensory neural hearing loss. And they did genetic testing, CMV testing, and high-resolution imaging. And they were able to identify a cause or diagnosis in greater than 2/3 of these children. This is similar to what I see in my own practice now. And this is dramatically different than even 10 years ago, when the majority of individuals we did not have a diagnosis for. So what I'd like to propose is we stop thinking about and focusing on the hearing loss. And instead, we change to looking at the deaf or hard of hearing person. And the diagnosis, which could be many of really hundreds of different things. So they could have CMV-induced inflammatory damage to the organ of Corti, for instance, or they could have cochlear nerve hypoplasia, or they could have TMC1 deficiency. There's really hundreds of different diagnoses that make up or that can cause this symptom of hearing loss. And that's what leads to reduced hearing. What this really provides for us is personalized care, which is what we all hope to provide to individuals. So as we know, some individuals will choose hearing aids, some will go with cochlear implants. We have auditory brainstem implants for individuals who are unable to use cochlear implants and willing. And then I told you about Valga and cyclovir, and we'll talk more about gene therapy. We also need to all remember that in many cases, none of these treatments will be what the family chooses or the best treatment for that family. For instance, the cochlear nerve hypoplasia. And so sign language or alternative forms of communication may be what that family chooses. My goal in my clinic is to provide the best care for the individual. And I believe that by focusing on the diagnosis and not the symptom, we're able to come up with the best answer. And of course, a team-based approach like we do at Boston Children's Hospital is really beneficial in this respect. So that's how I wanted to frame things before I actually got started with the talk, which is about genetic testing. We're going to talk about sort of a who, what, why, when, how overview here. So we'll talk about what is genetic testing, why should we perform it, who should receive it, and how should a clinician order it. And while we're going through this, I'm going to present 4 different patients from my practice that I've seen that I think demonstrate the power and the importance of genetic testing and genetic evaluation for individuals who are deaf or hard of hearing. So what is genetic testing for hearing loss? Well, if you look at all children that have hearing loss, this sums up the causes of congenital hearing loss. So about 2/3 or 65% is considered genetic. About 10% is an anatomic abnormality. About 20% is congenital CMV, and somewhere about 5% is due to ototoxicity or trauma, usually surrounding birth. And the genetics of hearing loss, as shown here, if we look just at the genetic causes, about 80%, about 1/3 of genetic causes are syndromic. So this means that there's other clinical features associated with the hearing loss. So there's Usher syndrome, which includes hearing loss, as well as progressive blindness caused by retinitis pigmentosa. There's Pendred syndrome, Waardenburg syndrome. These are just the most common. That makes up about 30% of genetic hearing loss. About 70% is non-syndromic, and this can be inherited in all different forms. The majority is inherited in a recessive fashion, which most typically means that the parents of the child who's deaf or hard of hearing do not have hearing loss. But hearing loss is extremely genetically heterogeneous. So what I mean by that is there's 124 different known hearing loss genes. And this is what makes studying hearing loss and testing for hearing loss so difficult. You know, sometimes I wish that I had studied something like cystic fibrosis where there's really only one gene that can cause the majority of cases. But at the same time, I think this is what makes studying hearing loss so interesting. So if you look at a large group of deaf and hard of hearing individuals, in this case, I'm showing data from more than 2,400, there isn't one single gene that makes up the majority of cases. So here you can see GJB2 or connexin 26 is about 20%. Stereocylin or STRC is the second most common cause of hearing loss, but far and away is the most common cause of mild to moderate hearing loss, which I'll be talking about later. So because of this extreme genetic heterogeneity, it makes testing very difficult. Truly, genetic hearing loss is complicated. And so what we realized about 14 years ago is that comprehensive genetic testing using massively parallel sequencing is key. So that's a lot of words. But what I mean is you can't just test one single gene at a time for an individual. You really need to test all the genes. So let me back up and talk a little bit about the history of this. So the Human Genome Project was completed in 2003. And some people on the call may not remember this is what computers used to look like. These are some of the DNA sequencers that were used to complete the Human Genome Project. And they used a technology called chain termination sequencing, which was developed in the 1970s. And it cost $8,000 per million base pairs. This meant that the human genome, the initial sequence, cost several $billion to perform the sequencing. This is what new sequencers look like. And this is from one company called Illumina, that's the predominant sequencing company. It uses something called massively parallel sequencing. And we don't have to get into all the details, but you can see essentially it's sequencing that's performed on a massive scale in parallel, which means that, at the same time. And this has dramatically reduced the cost of sequencing over the past 15 years since it's been developed. So it's less than $1 per million base pairs, and we can do 80 billion base pairs in 24 hours. So we realized very early that this is exactly the technology that was needed for something like genetic hearing loss, which is so complicated. In my lab now, I have a sequencer that actually fits in the palm of your hand. So this is the newest sequencing technology, and it actually pulls a single molecule of DNA through a pore and sequences at a time. So the new developments in sequencing technology, they're evolving all of the time, and it's really amazing. But what this means is that the $1,000 genome is here. So for years, people were talking about how things will change when it costs $1,000 to sequence a genome. Now we do this essentially on a daily basis at Boston Children's Hospital, where we do genome sequencing for $1,000. You can see in the early 2000s, it was $100 million or more. So the fall in cost is dramatic. So this is the technology that we use to perform comprehensive genetic testing for hearing loss in 2009 and 2010. So what this meant is that for the first time, we could sequence all the hearing loss genes all at once. And this technology rapidly propagated. You can see within just a few years, there were many different publications. We published several years after using this technology for 1,119 patients. And a group from Japan came out soon after with 1,120 patients, just to show they could beat us. But what this means is that this technology has now been used for hundreds of studies and thousands of patients. There's now several different companies around the country that perform this testing, or a similar version of this testing. This is the test that I helped develop at University of Iowa, but you can see there's other companies here. I don't have any financial relationship with any of them. But this comprehensive genetic testing for hearing loss has now become the standard of care for evaluation of childhood hearing loss. All these different tests essentially do the same thing. So they use these new sequencing techniques to sequence all the non-syndromic hearing loss genes, as well as many of the syndromic hearing loss genes, like Usher syndrome and Pendred syndrome, because we're better able to test for them at the same time, and we're identifying these syndromes earlier and earlier. So why do we perform genetic testing for hearing loss? Well, really, the easiest answer is it's the single most effective test. So if you look across all studies, and this is relatively even, and it's been similar for the past 8 years or so. If you just order genetic testing on an individual that has hearing loss, the diagnostic yield, or also known as diagnostic rate, is about 40%. So that means that in 40% of people, we come up with a diagnosis. I'll show you some slides later showing that for children, this is higher. So it's more like 50 to 60%. But if you just ordered a CT scan or an MRI, the diagnostic rate would be lower, so closer to 30%. And even when I started training, we would do other testing, like we'd get ultrasounds and blood tests. And these tests don't really have very much of a diagnostic yield. It's very low. The other important reason to do genetic testing is because it provides really important information for families. It provides prognostic information, so whether the hearing loss will stay the same or get worse over time. It also provides information on recurrence risk for patients and families. So if they were to have another child, what the chances are that they would be affected, or when their children go on to have children, what the chances would be that they would have hearing loss. And then importantly, it evaluates for syndromic causes of hearing loss, which we're finding really does comprise about 20% of diagnoses. And what I think may be one of the most important things, if not the most important thing, is what I find for my families is it really empowers the patients and the families. And what I mean by this is instead of just having a symptom, like I talked about, it provides a diagnosis. So this is, for instance, the stereocylin gene mutation hearing loss Facebook group. And one of my patients' families started this, and they have many members of this group now. And it really provides a sense of empowerment for these families so that they can meet other members of their community and they can share their diagnosis. So I'd like to talk about the first patient. So this individual is a 7-month-old who referred on their newborn hearing screen bilaterally. And you can see an audio that we have here where it's profound hearing loss bilaterally. And the family was really on top of things. You know, they had hearing aids since 3 months old, and by 7 months was meeting developmental milestones. You can imagine the questions that the parents would be asking. So what's the cause of the hearing loss? What's the prognosis? What the recurrence risk is? Well, we did genetic testing, and we came up with 2 pathogenic variations in the gene CDH23. This is the most common cause of Usher syndrome type 1. This is severe to profound hearing loss with vestibular dysfunction, which can lead to delayed motor milestones, as well as progressive vision loss due to retinitis pigmentosa. And so these are some of the most difficult days that I have in clinic is providing this result back to a family. And it's really a unique position that as an otolaryngologist that I have quite routinely where I'm providing a diagnosis of a vision problem before it even occurs. But because otolaryngologists are often ordering genetic testing, now we're often the providers who give this result back. I will tell you that having this diagnosis of a dual sensory impairment really changes the discussion for possible treatment options. It really reframes our conversation thinking about cochlear implants, for instance. And although providing this result back to families can be very devastating, universally, when I talk to families after they've had some time, they've been so thankful to have the diagnosis just because they're able to do things like teach their child Braille before they start to lose vision. And they can take vitamins like vitamin A and wear sunglasses to delay the onset of retinitis pigmentosa. So although this diagnosis is very hard to give, it's very important for us. So some of you may be thinking that the diagnostic rate for genetic testing is really low. It's 40%. And, you know, sometimes I'm thinking kind of negatively about that too. And I was talking to one of my colleagues who's a neurologist, and I said, oh, our diagnostic rate's so low, it's 40%. And she said, what are you talking about? That's great. So I started looking into it. And these are genetic disorders, neurologic disorders that they routinely order genetic testing for. So it's very common now to obtain genetic testing for autism. The diagnostic rate for that is about 17%. Almost every child now with epilepsy undergoes genetic testing because there's specific treatments that are available for them. Even then, the diagnostic rate's about 24%. And then children with intellectual disability routinely undergo genetic testing. That diagnostic rate's 28%. And now in the NICU, it's becoming more and more common to obtain rapid genetic testing and rapid genome sequencing to provide a diagnosis. And this is hugely expensive because they try to get the result back within 24 or 48 hours. And the diagnostic rate there is about 36%. So actually, our diagnostic rate is about 40%, which is higher than any of these. So what this means is that as a provider taking care of individuals who are deaf or hard of hearing, you all are geneticists. So it's important for all of you to understand the genetics of hearing loss as well. So I wanted to talk about another patient. So this is an 18-year-old that I saw who had this congenital hearing loss. And it was, as you can see here, it was mild to moderate with a little bit of a mixed component. And this patient had eustachian tube dysfunction, had a bunch of tubes placed. And so her whole life she was dealing with, tubes and draining ears, and no one had ever brought up her sort of underlying hearing loss that she had kind of been struggling with. It was attributed to her tubes and her eustachian tube dysfunction. So she wore hearing aids, but not all the time. She also struggles with ADHD. So because we have a research study at Children's, we were able to enroll her in this, and we performed genetic evaluation because she really just wanted to know what the cause of hearing loss was and what the prognosis would be. So she's 18, so she wanted to know whether it would stay the same or get worse over time. What we found was a pathogenic variation in the gene FGFR3. And at the age of 18 years old, we were actually able to give her a diagnosis of Menkes syndrome. This is a syndrome that's associated with craniosynostosis, so abnormal early fusion of the skull, and hearing loss, as well as ADHD. And so finally, at 18 years of age, she was provided with a diagnosis. And this was hugely impactful for her because the next time that I saw her back, it was almost like she had accepted her diagnosis more, and she was wearing her hearing aids. Dylan Chan, who's at University of San Francisco, has shown that providing a diagnosis to children increases their use of hearing aids. For this reason, I think it's important that we pursue this. So the other point I'll make about this patient is that for a lot of these syndromes, there's something called a syndromic spectrum. So what I mean by that is when they first diagnosed or first came up with these syndromes years ago, they probably looked at the most severely affected. But what we're finding is if we perform testing of more individuals, we're able to find that there's some that have more of a mild phenotype or more mild clinical features. And so this was very important for this individual, even though this is not someone that you would typically think, oh, we should do genetic testing for, but I'm glad that we did. So more about the prognosis and management. So I just wanted to show you two different genes that have a very different prognosis. So these are combined audiograms of different individuals with two forms of hearing loss, TECTA and KCNQ4. And what you can see is that over time, the hearing loss for TECTA is relatively stable. The hearing is relatively stable. Whereas for KCNQ4, there's about a 10 decibel drop per decade that we can see here. And so as I told you, this really reframes how we think about cochlear implants versus hearing aids. And on a day-to-day basis, if I have a genetic diagnosis, it changes how often I recommend a repeat audiometric evaluation. So if I know that a child has a stable form of genetic hearing loss, we may be able to push a visit out to 1 year, whereas otherwise we may see them back every 4 to 6 months. So it does change my clinical practice on a day-to-day basis. Another reason why is consensus guidelines. So now there's been a couple different guidelines from the International Pediatric Otolaryngology Group and the American College of Medical Genetics and Genomics. And these both say that genetic testing should be part of the evaluation of children with hearing loss. I also want to talk about cochlear implant outcomes. So if you look at any group of cochlear implant patients, you may see something that looks like this. So their post-operative word recognition scores are on average something like this. So 70% for one test, CNC, about 60% for another test, AZ Bio. But what's underlying this data is actually a huge variability in outcomes. So there's some individuals who had a cochlear implant and they get 0% word recognition. and others may get 100%. I really find this, to be frank, quite unacceptable, because I'd like to be able to counsel my families, the children that I see, effectively as far as how well a cochlear implant is going to work. And so that's a big part of my research, is try to understand these cochlear implant outcomes. So we know that these outcomes are variable, and can we improve outcomes with a better understanding of genetics is the question. So cochlear implant outcomes, it's clearly complicated. So we know that there's things like the environment, so socioeconomic status, time without hearing, the social interactions, these clearly play a role in cochlear implant outcomes. And then there's clinical variables. So things like what device is used, what surgeon, what postoperative complications, and then the activation and the training afterwards. Well, I would propose that genes are likely involved too. So genes that could affect the sensory pathway as well as the central pathway, so the brain. And I really do think that a better understanding of cochlear implant genetics could allow us identification of poor performers preoperatively. So what I mean by this is that if we think that someone's at a high risk of not doing as well with a cochlear implant, we could focus the activation and training and follow-up for those at-risk patients. And then really importantly, I like to be able to counsel my families and patients effectively with how I expect that they're going to be doing after a surgery. And then ultimately, this could also pave the way to precision-tailored cochlear implants. So to get into a little more detail about this, if you think about the auditory pathway as the schematic here, so you have the hair cell, you have the nerve, and then you have the brainstem. The cochlear implant electrode bypasses the hair cell and it stimulates the nerve. Our hypothesis would be that individuals that have a damaging genetic mutation or variant affecting the spiral ganglion will have significantly worse cochlear implant outcomes. So what I mean by that is that it's actually been known for a while now that if you have sensory dysfunction, so if you have a genetic variant that affects the hair cell specifically, like GJB2 for instance, these are some of the best performers with cochlear implants. Whereas we hypothesize that if you have a neural dysfunction due to genetics, so if your nerve is not working as well, you may have a poor outcome. Well, there's 92 or close to 100 different genes that affect the organ of Corti or the synapse, and there's a fewer number of genes that affect the neuron directly. So we looked at this a few years ago, and what you can see here is that when we looked at a z-scored average of individuals that had a genetic cause that was neural or a sensory cause of hearing loss that was genetic versus things like otosclerosis and Meniere's and sudden hearing loss, the individuals that had a neural genetic cause of hearing loss performed worse overall than those that had a sensory genetic form of hearing loss. So I do think that genetic variants that affect the auditory nerve are associated with worse cochlear implant outcomes. There's a lot more work that needs to be done in this area to do this study again with a greater number of patients, and this was adults. So I want to talk about another patient. So this is a patient who came to see me for a cochlear implant evaluation. This is what the audiogram looks like. So it's sharply downsloping, normal to severe to profound hearing loss. This patient's word recognition scores were decreasing significantly over time. And they wanted to know what the cause of the hearing loss was and whether a cochlear implant was the right treatment or whether they wanted to continue with hearing aids. Well, we did genetic testing. We identified pathogenic variants in the gene TMPRSS3. This is a cause of non-syndromic hearing loss. And it's very controversial, but some groups have shown that individuals with this form of hearing loss have worse outcomes after cochlear implants. And this is still, there's conflicting data one way or another on it. But we had a long discussion about this because I want to make sure that individuals are adequately counseled prior to cochlear implantation based on their diagnosis. I should point out, though, that I'm not saying that individuals with TMPRSS3 hearing loss or other genetic forms of hearing loss that may be associated with more poor cochlear implant outcomes should not have a cochlear implant, because cochlear implants for individuals who want that are the most effective available treatment for severe to profound hearing loss. And so my point overall is that we should work towards better counseling based on a diagnosis. Because after all, some individuals do very well with the cochlear implant and TMPRSS3 hearing loss, for instance, but you would like to be able to counsel effectively. So another reason why is gene therapy for hearing loss. So this is a rapidly evolving area right now. I'm going to talk just for a minute about it today, and maybe in a future forum I'll talk more about it. But I have very mixed feelings about moving forward with this gene therapy for hearing loss, and we can get into that at another date. But there are different methods for molecular therapy for hearing loss. So there's replacing a gene or suppressing a gene or editing a gene. And there's all sorts of considerations like the ethics of doing gene therapy for hearing loss just to begin with. We don't know how well it's going to work. The virus could have systemic effects, so in the whole body, and how safe it is. But the point is that any genetic therapy requires an accurate genetic diagnosis first. So you can't even think about gene therapy unless you have an accurate genetic diagnosis. And I will say that whether you like it or not, gene therapy for hearing loss is here. So I think most of you have heard that there's 2 companies now who are opening up clinical trials for gene therapy for hearing loss. I have no financial relationship with either of them, but one company is Akuos and the other is Decibel, and they're both opening clinical trials this spring and summer for OTOF or otoferlin genetic hearing loss. And you can see from their websites, their next targets are things like GJB2, which is, as I told you, the most common genetic form of hearing loss. And so this is happening now. And again, as individuals who, or providers who care for children that have hearing loss, this is something that you should all at least know something about. So the last patient I want to talk about is this patient. So this is their audiogram. So they have a mild to moderate symmetric sensory neural hearing loss. Again, this is maybe someone that you wouldn't necessarily automatically say we have to get genetic testing for. But this is a 7-year-old who didn't pass their newborn hearing screening, otherwise healthy, and is doing great with hearing aids. But the family wanted to know about the prognosis primarily. And they're also very active and wanted to be involved in their child's care. We were able to provide them with a diagnosis of STRC hearing loss because of deletion of the stereosilin gene. I told you this is the 2nd most common cause of genetic hearing loss overall, and by far the most common cause of mild to moderate hearing loss. And now that we're testing these individuals, we're finding this more and more frequently. There's a long background to this gene, but it's very hard to sequence. And so until these new technologies came along, we weren't able to test for it very well. And now we're finding it's much more common than we realized before. But the first thing that this family wanted to know after we gave them this diagnosis is whether there was a gene therapy available. And you may be looking at this hearing test and say to yourself, well, they wear hearing aids. Why would they want gene therapy? Again, this is where I would argue that we need to care for each family as they would like to be cared for individually. And so here at Boston Children's, we showed that gene therapy for STRC hearing loss is effective in mice. So this is showing electron microscopy of the hair cells of a mouse. And you can see on the left is the hair cells that were treated, and on the right, the hair cells that are on the left is the hair cells that were untreated, and on the right are the hair cells that are treated. You can see that they're standing in nice straight rows again. So this family, every time I see them, they ask about gene therapy for hearing loss. And as I told you, the companies have this on their horizon. And so the next 5 years, the whole landscape's really going to be changing, I think. So who should we be performing genetic testing for hearing loss for? Well, the diagnostic rate varies by clinical characteristics. I told you that overall the diagnostic rate was about 40%. This is data from a few years ago now. But if there's a family history of hearing loss, the diagnostic rate can be higher. If the age of onset is earlier, the diagnostic rate is higher. And if it's symmetric hearing loss, the diagnostic rate is higher as well. So when I see a child that has congenital profound sensorineural hearing loss in a normal physical exam, I tell them that they have about a 60% chance of having a diagnosis from genetic testing, which is really remarkable. The genetic diagnosis really varies by age. So when we look at cochlear implant patients, this is 100 pediatric cochlear implant patients. Here, the diagnostic rate was about 48%. And you can see all the different genes here. So GJB2 is the most common. But when you look at adults, the diagnostic rate is lower. So it's about 22%. And this is for a whole number of reasons that I don't have time to talk about today. But the genes that are affected are totally different. So you can see that TMPRSS3, that one gene that I talked to you about with cochlear implants, is the most common genetic cause of hearing loss in cochlear implant patients who are adults. So it really varies based on age. We also know that genetic diagnosis varies by race and ethnicity. So GJB2 is the most common cause in Caucasians and Asian individuals, but it's essentially non-present and non-contributory in African Americans. So if you were to just test for GJB2 in African Americans, it would not be effective. Dylan Chan at University of San Francisco has done some amazing work looking at the genetic diagnostic rate based on sociodemographic factors as well as race and ethnicity. And what he showed is that Hispanics and Blacks were actually 5 times less likely to receive a genetic diagnosis as Asians and whites. This is hugely important that we work to reduce this inequity in genetic testing. And it's a focus of my lab as well as others around the country. So just to show you what a diagnostic evaluation would look like for a child with sensorineural hearing loss, they have history, physical exam, audiometric testing. We obtain CMV testing, and then we look for specific physical exam findings. If we see something that's clearly syndromic, which is often very difficult in young children, then we do genetic testing based on the syndrome. But in the majority of cases, we have an individual who has non-syndromic sensorineural hearing loss. If it's bilateral, including asymmetric hearing loss and auditory neuropathy, we start with comprehensive genetic testing. We obtain an ophthalmology evaluation just to make sure there's not a dual sensory impairment. We get an EKG because it's cheap and non-invasive, and we don't want to miss any cardiac problems. And then we talk to them about imaging. And the time frame of this depends on whether we're thinking about a cochlear implant or not. If it's unilateral hearing loss, then essentially we rely more on MRI or CT scan. And this is essentially the algorithm that I use on a daily basis in my clinic. You can see that genetic testing forms a cornerstone of it. However, we've started to wonder whether we should do genetic testing more for unilateral and asymmetric hearing loss. So this is some more recent data just from last year showing that our diagnostic rate by symmetry, if you look at bilateral, it's about 40%, asymmetric, it's about 20%, and unilateral hearing loss, our diagnostic rate was about 18%. But maybe what's more important is the number of syndromic diagnoses that we make. So for bilateral symmetric hearing loss, about 20% had syndromic diagnosis. So this is Usher syndrome or Pendred syndrome. But it was 33% for bilateral asymmetric hearing loss. And actually more than half of the individuals we diagnosed who had unilateral hearing loss had a syndromic diagnosis. So you could argue that the unilateral hearing loss children are maybe the ones that a diagnosis is the most important for, because that's what really can change their clinical care. So this data has really changed how I think about evaluating kids with unilateral and asymmetric hearing loss. And I do think we should be performing genetic testing for them. So how do we perform genetic testing for hearing loss? I told you there's many companies. So there's a 1 to 3 month test turnaround time. This can be ordered by an otolaryngologist. And many of these companies provide genetic counseling associated with it. And the cost is $1,000 to $4,000. So that seems like a lot, and it is a lot. But I will tell you that for our patients, when we looked at the last 100 patients that we evaluated, 64% of the time insurance actually covered the genetic testing, 81% of the time with private insurance, and our Mass Health actually covered 50%. So this is hugely different from 10 years ago when insurance almost never covered genetic testing. Now in the majority of cases, we can say that it's covered by insurance because insurance companies have realized that it's really integral to care for these individuals. So I hope I've shown to you that by focusing on the diagnosis instead of the symptom, we're able to decide the best treatment for the individual. I want to leave you with some future direction. So one thing that I think about, and hopefully I'll have a chance to talk to you more about at another forum, is finding the therapeutic window. So we know for things like cochlear implants, and I'm guessing for something like gene therapy, that the therapeutic efficacy decreases over time. And this is probably a combination of things like the spiral ganglion neurons and neuroplasticity that decreases over time. And then also when you think about single-sided hearing loss, there's a side preference that develops. And what is pretty incredible is that even at Boston Children's, where we have incredible amount of resources, our average age of diagnosis for congenital hearing loss is about 13 months. So what I mean is we're providing an actual diagnosis to these children. So this is what our sort of therapeutic window looks like now. But in order to improve our therapeutic window for things like cochlear implants and in the future gene therapy, we need to think about shifting that diagnosis earlier. And the only way we can do this is by improving newborn hearing screening, which I know is very important to all of you and very important to me as well. So the take-home points are that hearing loss is a symptom. It's not a diagnosis. And a diagnosis for individuals who are deaf and hard of hearing, it provides the individual, family, and the clinician with tons of valuable information, and it ultimately allows for personalized care. And so I hope you can understand that I've reframed how I think about this, and I'm trying to get other otolaryngologists to think about this differently. Instead of looking at the hearing loss, we're coming up with a diagnosis just so we can start to think about the whole child and what's best for the child instead of just their symptom. And with that, I'd like to thank Dr. Kane, my close clinical and research collaborator, and then everybody in my lab. Thank you, and thank you all again for your attention. I really appreciate it. I'm happy to take questions.
Yeah, thank you, Dr. Scheer. This is Will Eiserman again from the National Center for Hearing Assessment and Management. And we've got some questions coming in, and I wanted to start off by asking you this. It seems like there are so many hot button issues related to what you talked about today. And it's important, I would think, that they don't get unnecessarily conflated. There is the issue of screening children genetically at birth who have a hearing loss, because that can inform treatment, regardless what that treatment is. And then there is how it might inform the decision around specific treatments like cochlear implants. And then there's that even hotter button issue of whether we should be going down the path of genetic treatment. So can you just say a few more words to try to isolate those separate concerns so that they don't unnecessarily get conflated?
Yeah, it's a great point, and they are all connected, but you can also think about them separately. So another way to think about it is that when we perform genetic testing, we make sure that families first of all, want to do the genetic testing, right? It's up to the family and the parents and the individuals. So that's opting in to it. So we would never force something like this. We also want to make sure that we're providing early screening and the best possible screening. So I didn't talk about genetic screening, and hopefully I will at another time, but using genetics, I think we will be able to improve our newborn hearing screening by detecting individuals that may have a later onset hearing loss right outside of the newborn period, or things like auditory neuropathy, or more mild hearing loss that may be missed on the current physiologic screen. So there's a way to use genetics just for screening. When you do any screening with genetics, though, you will have an individual who can opt in or opt out of receiving the results. So they may have a screen that says, you failed the genetic portion. Do you want to know the results or not? So you can use genetics to just perform a screen without providing a diagnosis. I think most families would want to know the diagnosis because of all the important information that it provides you. But any genetic screen would need to be followed up by a full genetic evaluation afterwards. And then the idea of, gene therapy and moving forward with that, again, that can be held totally separately, and that's something that's not going to be available for many or most families. And so it's up to the family whether they want to pursue that treatment option, just like cochlear implants are now. We would never force that on them. Does that answer your question, Will?
Yeah, thank you. I know that because I've heard you speak before about how important it is for you to make it clear that you're about having as much information as you can when you consult with families so that they can make the best decisions that meet their family's needs. And I know that's where you're coming from, and I just wanted to make sure that you had an opportunity to clarify that, given how hot some of these other issues are.
Yeah, that's it. That's exactly right. I really want to empower patients and families to make the best decisions for them, ultimately.
So here's one of our questions from our participants today. Can you explain why surgeons may be implanting CIs on kids with no detectable audiological nerve? This person says, I have seen no increase in hearing for this population.
Yeah, that's a great question, and you could have a whole seminar on that. That's totally dependent on the center, and it's, I can only speak for what we do at Boston Children's, which is we have an interdisciplinary group of audiologists, speech pathologists, surgeons, social workers, and we discuss every family and we come up with sort of treatment options. It's there are some children who have surprised us in that it looks like there's not much of a nerve and they can do very well, but it's actually very rare at our institution that we would perform or offer a cochlear implant that has no nerve that we can see. Actually, we essentially don't do that. I don't want to speak for our whole group, but I would not recommend that. So I know there are some people that proceed with cochlear implantation if there's no known detectable nerve. You would need to be able to counsel them really effectively as far as the risks and benefits before. I hope that answers your question.
So here's another question. Such interesting questions are coming in. Given that congenital CMV is so common, do you also test those patients for genetic causes of sensorineural hearing loss, or just assume it was CMV?
This is such a great question. This is a really important topic to me because exactly as you said, CMV is very common and genetic hearing loss is very common. And we have now seen several patients who are being treated with valganciclovir for congenital CMV, and we perform genetic testing on them, and we've actually find they have a genetic cause of hearing loss. And so then we will stop the treatment for valganciclovir. So our protocol at Children's is that any child with genetic or any child with hearing loss, we recommend they undergo genetic testing if the family is interested, because it does change our treatment, because we do not expect valganciclovir to help genetic hearing loss, for instance. So I would say, even if you think it's congenital CMV, you still need to test for genetic hearing loss. And even if you think it's genetic hearing loss, you should check for CMV. You need to do both.
Yep. So CMV does not preclude there being another explanation.
Exactly. Yep.
The next question is STRC on the regular genetic hearing panels. Would it only catch deletions? What about mutations? This person says, I asked because my sons both have a mutation of STRC, not deletion, and it was only caught by Columbia's genomic project. It did not show up on their genetic hearing panel.
Yeah, I alluded to this. This gene is very, very difficult to sequence. And the new technologies that we have are getting better and better at sequencing. So we have an example of an individual who we did the standard panel and nothing was detected. We did the next level, which was exome sequencing, and nothing was detected. And then we did one of those new DNA sequencing technologies I told you about that are very long read sequencing, which are very expensive. And finally, that detected an STRC deletion. So it's very hard to identify, and it's really relies on new technology. So I still do think that we are missing some individuals that have stereosilin gene mutations or gene deletions. Most panels now include detection of deletion and the mutation, but I don't think that they're capturing all of them, just because it's very difficult to do that.
Yeah. I don't think we're going to get to all of our questions, but let's go for another one. And this is a comment from an individual who identifies as deaf since birth. The individual says, I'm a carrier of the GJB2 gene. My partner and children all have the gene, and another I cannot remember the name of. I wanted to just share that deafness is the only disability that has a culture and language, and that I believe it would be unethical to do gene therapy to perform eugenics on deafness. Do you have a comment about that?
Yeah, I mean, again, you could spend a whole seminar talking about gene therapy, and I hope we do sometime, just so that we can better educate everyone. The way that gene therapy is being talked about for hearing loss is as a treatment. So it's an injection into the inner ear. It doesn't actually change the reproductive organs of the individual, for instance. That's a common misconception. So eugenics would be something to actually erase a group of people. It's a different treatment option is how it's looking right now. Similar sort of surgery to cochlear implantation, but without the implant. So I would never force any sort of treatment on anyone. I want to best treat individuals and families how they want to be treated ultimately. But I completely respect that opinion of yours.
There are a number of questions, and let's maybe end with this question. And if you have other questions that you would like to pose to Dr. Shearer, please send them to us. We'll put that in. Gunnar, if you could put my email address or the help desk in the chat, then we can forward those questions on to Dr. Shearer. There are a number of questions that are coming in that all have to do with this statistic that we all hear about how many children are born with permanent hearing loss to families that do not have a known history. And yet, does that necessarily mean there isn't a genetic component? Can you separate those two issues so that we get a clear understanding of that?
The majority of genetic hearing loss is recessive, which means that in most cases, the parents do not have a hearing loss. And it's the combination of the two parents' separate genes that make the child and makes the child different. So that's the reason that we're all not clones of our parents, because it's the combination of the parents that make us, right? So I think that answers your question, Will.
Yep, thank you. And it was not mine, it was many others.
Yeah, okay.
So we are at the bottom of the hour, which means we're at our closure here. Before you all run off, Gunnar is going to post a link in our chat on that will take you to a quick survey and a certificate of attendance generator, so that if you need evidence of your participation in today's webinar, you can get that there. Dr. Shearer, we'd love for you to come back and talk specifically about the use of genetic screening as a part of the newborn hearing screening protocol. And so we'd love to get that on the books sometime soon with you, if you're open to that, because there's a lot of practical questions about the feasibility of doing such a thing.
Yeah, I'd love to. Thank you.
Yeah, thank you everybody for your time and attention today. This webinar has been recorded and will be posted on infanthearing.org in the next couple of days. Keep that in mind if you need to review any of this again for your own benefit, or if there are individuals who didn't attend live today whom you think might benefit from this information. Thank you, everybody, and a thank you to our captioner and to our ASL interpreter. We really appreciate your talents, expertise, and availability to help us make this webinar learning opportunity as accessible as possible. Thanks, everyone.
Thank you. Thank you to the interpreter and the captioner too. Thanks for your help.